Hello, my topic is symptoms of damage to the brachial plexus, radial, ulnar, and median nerves. So basically, brachial plexopathy and neuropathy of mononeuropathy of the radial, ulnar, and median nerves. Brachial plexopathy. The symptoms, the causes are many, but as my topic is about symptoms, I will just explain the symptoms. For example, when an infant is born, his shoulder might get stuck in the birth passage and it may cause shoulder dystocia, which causes Duchenne palsy or palsy of the nerves C6 to C8. And it causes upper arm weakness because C6 to C8, they innervate the lateral part. Well, not exactly shoulder, from the lower arm to we have the ulnar nerves arising from them. It causes upper arm weakness with sparing of hand because it doesn't innervate the hand motor. Clump K palsy is C8 to T1. It causes paralysis of hand because C8 to T1, it innervates our and flexors, and the upper arm is spared. You can remember this by the occur when you wear your backpack. It causes the shoulder and also may cause distension of the brachial plexus. It causes upper arm weaknesses. Then we have a major syndrome called the Parsonage-Turner syndrome. It's initially severe axillary and or shoulder pain and subsequent weakness in arm involving upper plexus. It depends on the extent of the pressure applied on your brachial plexus. It's all these palsies and plexopathies are mainly the symptoms are weakness, but sensory loss may be present. And the two nerves commonly affected are long thoracic nerve, which arises from the brachial plexus and goes down, and the anterior interosseous nerve. And you can see that their innervation is scapula and distal thumb flexors and index finger flexors. So the weakness is in those muscles. Next, please. Okay, so median neuropathy. The most common, as we all know, is carpal tunnel syndrome, pain and paresthesias of the hand. When we use our hand a lot, for example, in typing, in writing, or in sports, it causes pain and paresthesia because the median nerve is suppressed in the carpal tunnel. But if the median neuropathy is proximal to the carpal tunnel, it's not carpal tunnel syndrome. It means is that the median nerve was not suppressed in the carpal tunnel, but before it. The symptoms differ. For example, it's not pain in the hand, but more like weakness of flexion in distal interphalangeal joints, in the flexor digitorum profundus, index, middle finger, and any or all of the weaknesses of the flexors of proximal interphalangeal joints. Then we have the anterior interosseous nerves and neuropathy. Mainly, it's the loss of ability to flex the thumb and first two fingers at the distal interphalangeal or dip joint. This leads to the inability to make the OK sign. This is the test we use to distinguish between anterior interosseous neuropathy and carpal tunnel neuropathy. Then we have ulnar neuropathy. Ulnar nerve entrapment can be at two different locations, but the most common is at the elbow and can occur due to direct compression, for example, leaning on the elbow for too long or sleeping positions in the night. And prolonged flexion, again, sleeping with a flexed elbow as in on your arm, and practicing the violin, or years after elbow injury. Tardy ulnar palsy. Entrapment of the wrist can be caused by prolonged pressure, bicycle riding, or any activities that cause pressure on the ulnar nerve, or due to a ganglion cyst in Guyon's canal. Patients with ulnar nerve entrapment at the elbow typically present with paresthesias in palmar aspect of the fifth finger, because the ulnar nerve, it innervates the fifth finger, palmar aspect, and distal aspect too somewhat, and the fourth finger also palmar aspect. But the fifth finger, or the pinky, is the most common one. Sensory deficits proximal to the wrist along the medial forearm is absent, but if it is present, it means there is a lesion of lower trunk, medial cord, or C8, and not ulnar neuropathy. We need to differentiate between those two. Sensory findings only occur distal in the wrist, involving fifth finger and medial half of the ring or the fourth finger. And Froment's sign, it's a test we use to distinguish between ulnar neuropathy and lesions of lower trunk or C8. As you can see, you ask a person to hold a piece of paper with his thumb without bending it. And if he is not able to do so without flexing his thumb, it means he has ulnar neuropathy. Radial neuropathy. The hallmark of radial neuropathy is wrist drop due to weakness of wrist and finger extension. Wartenberg syndrome, entrapment of the superficial branch of radial nerve with sensory manifestations and no motor deficits. You can see that the patient reports pain over distal forearm and paresthesia over the dorsal radial hand. Typically everywhere the radial nerve innervates. Posterior nerve and interosseous nerve and neuropathy. PIN is it's a branch of the radial nerve that supplies all radial nerve muscles except the triceps, brachioradialis, and extensors. The pin can rarely be affected in isolation, causing isolated weakness of finger and thumb. So typically, radial and posterior interosseous nerves are affected together commonly, and the common causes include trauma to elbow and repetitive arm movements. For example, some kind of instrument playing and or construction jobs. A common site of entrapment is at the arcade of Frost, the tendinous arc at the origin of the supinator muscle. That's your posterior part of the elbow just below, as you can see here, the arcade of Frost. And the Wartenberg sign is used to tell if it is well, radial neuropathy. You can see the patient is asked to hold his fingers fully with together, and if one of his finger, the pinky, deviates, it means, or abducts, it means he has a Wartenberg sign. Thank you. That's all.
That's all right. Reconnect, please, our Zoom.